This presentation is for Nursing 619 Scholarly Inquiry in Nursing. My evidence-based intervention is with regards to patient safety and medication errors. This presentation, I will go through my PICOT question, and my presentation will be in the SBAR format: situation, the background, the assessment, and the recommendation. The PICOT question, the group that I'd like to do my intervention on would be the adult-PACU nurses. The issue needing to be addressed is decreasing the risk for medication errors. I would like to compare the pre- and post-test results for education on the risk for medication errors. The outcome is to increase learning as evidenced by higher post-test scores, and the time frame would be a 1-month period to get everyone educated. So the question would be for adult-PACU nurses to increase learning on the risk for medication errors. I will compare pre-post test scores after educating nurses on safe medication administration practices. The situation and the reason why I would like to do this evidence-based intervention is due to the medication errors that we have experienced in the adult-PACU at Yale New Haven Hospital. In July of 2018, we had a bigger medication error where the PA had requested verbally at the bedside that the nurse would give the patient glycopyrrolate to treat slow heart rate. And so heart rate was probably around 40s to 50s, and the blood pressure was systolic in the 80s. And so the PA had ordered glycopyrrolate 0.2 milligrams to be given IV push. And when the PA verbalized that to the nurse had never given glycopyrrolate. And so what she did was she went to the Pyxis and she pulled phenylephrine. And she ended up giving the patient 1,000 micrograms, the entire amount of phenylephrine. And, you know, the patient ended up, their blood pressure, systolic blood pressure went into the above the 200s, and it caused harm to the patient. The patient ended up being going to the CCU for 3 days. The nurse in this situation, the PA had given a verbal order, and it could have been avoided had he put in the order into the computer and the nurse was able to draw the medication from the Pyxis and then scan the medication and then give it. But in this situation, that's not what happened. The nurse felt pressure that she, was rushed and ended up given a medication that she wasn't that familiar with. In August of 2019, we had another situation where the RN had started a LASIK strip for a kidney transplant. And the IV concentration for the LASIK strip was about 100 milligrams and 100 mLs. And the order was for 2 milligrams per hour or 2 mLs per hour. And the nurse had programmed the pump for 20 milligrams per hour or 20 mLs per hour. The nurse on the floor, once the patient transferred from the PACU to the floor, nurse on the floor didn't notice this until 2 hours later. So the patient had received a total of around 60 to 80 milligrams of LASIKs. And no harm came to the patient. The patient did fine. But when, discussed this with the nurse and asked her what happened, in this situation, she didn't program the pump, which we have smart pumps. She didn't program the pump for LASIKs to go through the pump. Another situation that happened in November was a nurse had scanned a fentanyl vial to give 25 micrograms. And when she went to give it, there were 2 syringes on her computer. She had scanned fentanyl correctly, but when she went to give the medication, she grabbed the syringe that had the Benadryl in it. And she ended up giving the patient Benadryl 25 milligrams instead of the fentanyl 25 micrograms. And she realized that after she had given it. There was no harm to this patient as well. And then another situation that happened in the same month was a nurse had scanned Imitrex 6 milligrams to be given subcutaneously. This nurse had never given Imitrex as well. She did scan the medication. She did read that it did say sub-Q, but she ended up giving it IV. This was a precursor safety event, but no harm came to the patient. The background as far as medication errors, according to Kleiger, medication errors harm at least 1.5 million people and cause approximately 7,000 preventable deaths a year in the U.S. An estimated 450,000 adverse drug events, according to Siebert, or medication errors that result in patient harm occur annually. Approximately 25% of those are actually preventable. So what I'm proposing in this intervention is a pre-test and a post-test. In the pre-test, I would like to, I'd like to use an outcome assessment tool using a survey questionnaire to be able to measure the outcome. The questionnaire will be given as a pre-test, education will be provided, and then a post-test. Now, the questions will be developed and reviewed and validated by a pharmacist, a safety nurse, and the nurse educator. The questionnaire will be given to 5 respondents to test. We'll give it to 5 respondents at our other campus at St. Ray's to their Adult-PACU. Since they're similar in demographics to our target population, the point or reason for doing this would be that they can assess into reliability and clarity. We'll give it to 5 respondents on that campus just so that they can read over the questions and give us feedback whether they felt that the questions were clear. Once the data is received, we'll tabulate it to summarize our results. Data will be analyzed using SPSS software with the guidance of a statistician. And then the spearmint rank correlation will be used to summarize the strength and the direction of the variables that were used. And the reason being is that this method will be preferred since the scales don't have clear distinction of how much one value is or if one is greater value than another. The plan or the intervention would be a PowerPoint presentation. In that PowerPoint presentation with the questionnaire for the pre and post test would be to teach these nurses, the importance of scanning and the importance to make sure that our scanning rates are greater than 90%. Some of the evidence and research has shown that in certain institutions that use an electronic medical administration record, that when nurses had scanned greater than 90%, there were less errors, medication errors that were committed. Another thing would be to compare medications with the electronic medical administration record. So for the nurse to take their time and actually look at the records as they're going through it, to make sure that their medications are labeled. Many times we may grab the wrong medication or we pull a syringe and we didn't label our medication. So making sure that they're doing that. Making sure, again, that checking 2 forms of patient's ID. The nice thing with the scanners and electronic medical administration record is that you're scanning, you're asking the patient, you're looking at their ID, and then you're also scanning their ID. And then also explaining the drug to the patient. I remember, the evidence showed this, is that many times when you're talking to the patient and you're saying, hey, we're going to give you these medications, just that conversation, this is for this is for that. And sometimes the patients may question you, say, I don't remember that medication. And that can also help in preventing errors. Also that the nurses would chart the medications immediately, not drawing the meds, giving the meds, and then scanning afterwards, but doing it all simultaneously. The biggest thing that I notice from the evidence is keeping the medication retrieval and administration free of distractions. There were different methods used. The evidence shared. There's a halt method where they make sure the person stops before they give any medications. Another one, one of them, they put on a vest, and so the nurses felt that this was kind of a little inappropriate. But whenever they would pull medication from the Pyxis, they would put on a vest just to tell everybody else, this should be a safe time. No one should be asking me questions. At Yale New Haven Hospital, they put tape around the Pyxis to make sure when anyone enters into the Pyxis area that no one should be asking them questions. Another article and research had used an example that what they do is they don't allow any phone calls to be made. The nurses, during the hour that they're given their medications, they cannot receive any phone calls from anyone, doctors, labs, patient's family member. The BA will kind of take care of all the phone calls and tell them they have to call back an hour later. That way they avoid any distractions. And also nurses, that they feel safe enough to report medication errors, that we promote this culture of safety, that they would share what errors may have been made without the fear of a punitive reaction from management. And then the other is easy access and use of the micromedics. Do the nurses know where to look up the medication uses? If it's a medication, according to these errors, that they've never given before, can they get to the micromedics? Is it easy and accessible, and is it easy to use so that they actually can do it quickly and be able to retrieve the information that they need before they give the medications? And that concludes my presentation. If there are any questions, I'll take those at this time. And I'd like to share my references. Thank you.